So first of all, what is an episiotomy? An episiotomy is a surgical cut on the perineum to create additional space to facilitate delivery of the fetus. This is the definition. So basically, you're making a cut on the perineum to allow more space for the baby to come out. Now, if you look at when I was a postgraduate, we used to give an episiotomy for almost all the patients, unless she was a multigravida or maybe a gravida 2 or gravida 3. For at least for all primary gravid patients, we would give an episiotomy. But over the years, and the thought was that by giving an episiotomy, you are reducing the incidence of perineal tears, right? So if you don't give an episiotomy, a spontaneous perineal tear is going to happen in 60 to 80% of patients, right? And if you give an episiotomy, it's a controlled tear. So there's a lot of controversy, however, recently, that should we give a episiotomy routinely? Okay, and now this new word has come about. Should we give an episiotomy restrictively? That means only in a select few patients should we give it. So this routine versus restrictive use of episiotomy has been the center point of a lot of debate in the last 5 to 10 years. A lot of evidence-based medicine came into play here. A lot of the Cochrane database, a lot of guidelines, American guidelines, WHO, RCOG. Everybody eventually said that we should not give episiotomy routinely. We should use it very restrictively. Now, why does this thought come? Does it not prevent perineal tears? That is the question. Yes, it does. So, episiotomy prevents severe perineal tears. Severe perineal tears, when I say, I'm talking about third and fourth degree, those involving the rectal, the anal sphincters and the anal mucosa. But it does not it is otherwise not useful. It doesn't prevent your first, second degree tears. Okay, so it's not going to help in any other way except preventing a severe perineal tear. And severe perineal tear, as such, happens only in certain situations. That is why its use is to be restrictive. So the word they've used is good clinical judgment should be used कि किसको episiotomy देना है किसको नहीं देना है. It's not that it doesn't reduce perineal tears, it reduces the incidence of severe perineal tears. But the earlier thinking was it's going to help in perineal tears as such. It's a very clean cut. You suture it well. The healing is better. But evidence is all against this. Evidence actually says that the incidence of healing, wound dehiscence, the incidence of post-op pain, dyspareunia, even pelvic organ prolapse, it doesn't prevent anything. Okay, so evidence goes against what we would think that this is going to be helpful. Evidence doesn't support this. Evidence only says that yes, when you have a difficult delivery, maybe say a shoulder dystocia or a after coming head of breech, or you're putting a forceps vacuum where you're going to anyway anticipate a third or fourth degree tear, वहां पे episiotomy डालो ताकि third, fourth degree tear no हो, but otherwise it is not routinely indicated. This is what evidence says. And this is from the WHO in 2018, okay, came out with the intrapartum care guidelines. Okay, and this includes the labor care guide and everything else. So it clearly said two things. One is it says to reduce perineal trauma, you should do three things. What are those three things? And this does not include episiotomy. It says do a perineal massage. What is a perineal massage? So if you've noticed in deliveries with our fingers, we do a massage, especially in the posterior fourchette of the introitus. We keep doing this. That's called a perineal massage. Applying a warm towel to the perineum, okay, in the second stage of labor, that softens the tissue, prevents tears. And third is your perineal support, the assistant who is giving support when the head is coming out by extension, when the shoulders are coming out. That perineal support should be there at all time. It's called guarding the perineum. You should have good perineal support are recommended. So these are the three things which are going to help you prevent perineal trauma, not an episiotomy. Okay. So the second thing they said is routine or liberal use of episiotomy is not recommended for women undergoing spontaneous vaginal birth. And if you go into the details of this, is I won't go into details because this is not a theory lecture, this is a practical lecture. Is this only? It is evidence does not find any reason to support giving an episiotomy in everybody. So if you don't give an episiotomy, please remember tear is going to happen. 60 to 80% of patients who do not receive an episiotomy, okay, like a primigravida, you after this class you think, oh no, ma'am said don't give an episiotomy, let's not give an episiotomy. But remember, that does not mean कि tear नहीं होगा, tear होगा. 60 to 80% will have a spontaneous first or second degree perineal tear, and suturing of these spontaneous tears apparently is not going to harm the patient in any way. That is what evidence says. Okay, so letting a spontaneous tear happen is better than giving a controlled tear. So do not interfere. Let nature take its course, but give perineal support. Put a warm towel on the perineum and do the perineal massage.